Okay, guys, so let's talk about how the mechanical events of the heart work. So, generally, if we go and get our blood pressure recorded, and this is the amount of pressure that's in our blood vessels, right? We might get something that comes back of like 108/68. That's normally somewhere around where mine is. So the top number there is what's known as the systole. And this is the pressure of the amount of pressure in the blood vessels when the heart contracts. And the diastole is the bottom number. And this is the amount of pressure that you see in your blood vessels when the heart is at rest. And basically, as we're going through this, there are basically 3 phases or 5 steps of the cardiac cycle that goes through following the left side, starting with total relaxation. And so when we're looking at the pressure being made, it's essentially going through what's known as ventricular filling. This is mid to late diastole, ventricular stole, and isovolumetric relaxation or early diastole. So we are going to watch a quick video to talk about this.
Physiology during systole. The aortic valve is open. Physiology on diastole. The aortic valve is closed. Physiology during systole. The aortic valve is open. Physiology.
Okay, I won't do that much longer for you. Sorry, guys. So let's go ventricular filling. This is what's known as mid to late diastole. And this is, and I'm going to show you a picture summary of all these and we're going to talk about them. But this is basically when the pressure is low, 80% of the blood will passively flow through the aorta, through the atrioventricular valve, into the ventricle from the atria. So at this point, the semilunar valves are closed. And essentially, atrial depolarization is going to trigger the atrial systole, which is the P wave, and the atria is going to contract, pushing about the remaining 20% of the blood into the ventricle. So this is basically talking about blood flowing into the atrium, and then the atrial depolarization to allow for the contraction of the atria is going to push the remaining blood. And basically at this point, depolarization is going to spread from the ventricles through the QRS wave. And the atria will finish contracting and return to diastole while the ventricle begins systole. So this is what's known as ventricle filling. And so this is just talking about how the blood is going to mechanically go from the atria to the ventricle. And so this ventricular filling is focusing on the atria because that's what's changing here to allow the blood to move from one basically chamber to the next. Now, the ventricular stole is going to happen when the atria relaxes. And this is when the ventricle is going to contract. And so this is going to increase the pressure, and that increased pressure in the ventricle is what's going to help close the AV or avioventricular valve. And so there's 2 phases within this. There's what's known as the basically isovolumetric contraction phase and the ejection phase. And so at the end of this, the end systolic volume is basically the volume of blood that's remaining in each ventricle after systole. And so this is the part for which you are getting the even contraction of the ventricle to push the blood that has at one in part one was going from the atrium to the ventricle. Now what it's doing is it's leaving the ventricle and going into the different circuits, right? And so this is what's known as ventricular systole. And the last, isovolumetric relaxation or early diastole, is when the ventricular repolarizes, and this is the T wave at the end of the ECG, and this is when the ventricles are relaxing. And at that point, the atrium are relaxed and they're starting to fill. Backflow of blood in the aorta and the pulmonary trunk is actually what closes the semilunar valves. Remember, they have those little bowls. And so when atrial pressure exceeds ventricular pressure, the AV valve will open and the cycle begins. So at this point, what's happening is the ventricle is starting to repolarize. It's relaxing to get ready for the next set of contractions. And at this point, because basically the atrium has relaxed previously, it's going to start filling with blood. And then it's going to push or get 80%, and it's going to start pushing into the ventricle, right? And then once the pressure that is in the atrium becomes higher than the ventricle or ventricular pressure, then the AV opens into the ventricle and the whole thing starts again. So let's look at this. So we have ventricular filling here in mid to late diastole. So basically, if you see here, right, this is where you're getting the pressure is low, and basically you're getting mostly all of the blood, 80% of it flowing through that open AV valve because the pressure in the atrium is higher than the pressure in the ventricle. If you look at this, you can see this, right? So let me see. So this is the pressure right here. If you look at the atrial pressure here, it is higher than the ventricle pressure that's right there. And so you can see over here, and it's overlapping. P wave is when the SA node starts, and it's going to contract, right? And so at this point, at that, you're going to see where it's going to start pushing that other 20% of the, essentially the blood going from the atrium into the ventricle. So you can see during this place, the AV or atrioventricular is open, but the aortic and pulmonary valves are closed at this point, right? And so you can see here that you start kind of low, and it's going to start way down here, and so you're going to start filling the ventricle with blood at this point. And so here, which is 2, right, you're looking at the ventricular systole. And so basically here, if you notice at 2A, is the isovolumetric contraction phase. And so if you notice, the pressure that's happening in the ventricle is going way up. That's why once it passes this, that's why you get the AV valve right there close. So it's that switch right there that happens, that the AV closes. And then it's going to increase here. And then what's going to happen is that you're going to get the aortic opening because you're starting to get the reduction in the volume here inside. So it's starting to push the blood out of into the different, both the aortic and pulmonary valves. And so you're going to see pressure increases. Basically, at this point, you're going to get the AV nodes that are closed, and then once we get into part B, this second part here, this ventricular ejection phase, then you're going to get where there's enough pressure in the ventricles, and the contraction happens. The ejection is the really strong contraction that allows the blood to leave, and that's going to be essentially what opens the aortic and the pulmonary valves. And so you can see here the volume that you see, the ventricular volume in males, is going down drastically here. And the pressure is going up until it starts to reduce because of the fact that you're pushing or ejecting that blood out of the ventricle. And then, of course, right here is where it switches again. And then you get because you get more pressure coming, the blood is now going in through the AV. So this third part, which is the isovolumetric relaxation, happens. This is what's known as early diastole. And basically what's happening here is that you're getting the relaxation of the ventricles. The volume is starting to increase again so blood can flow in. And you're going to start getting basically 80% of the blood just passively flowing into from the atria into the ventricle until we repeat the whole thing over again. And so it shows everything all the way through as they go through this process. And so at this point, I have online a cardiac cutout assignment that you can use to help you to understand this process better. So at this point, you can pause this and stop. Now what we're going to talk about is heart sounds, because we're getting really close to the end of this lecture. And so heart sounds, there's two sounds. You normally hear lub-dub, lub-dub. And those are associated with closing of heart valves. The first sound is the closing of the atrioventricular valves. So that's the tricuspid and bicuspid. And so those are between the atrium and the ventricles. The second sound is the closing of the semilunar, which is basically the aortic, and the pulmonary, which is basically from the heart to the body. The pause between the two sounds indicates the heart is relaxing. Now, the bicuspid or the mitral valve closes slightly before the tricuspid, and the aortic closes slightly before the pulmonary. And so these differences allow for the escalation of each valve when you listen to the stethoscope is placed in 4 different regions. So you can basically, that's the reason why when you are going to the doctor that they move around the stethoscope to listen to different parts of the heart so that they can basically focus on different valves. So the aortic valve sound is heard in the second intercostal space at the right sternal margin. The pulmonary valve, you can find the heart sound in the second intercostal space on the left sternal margin. The mitral valve sound is heard over the heart apex in the 5th intercostal space that lines up with the middle of the clavicle, and then you can see the tricuspid valve sound is typically heard in the right sternal margin of the 5th intercostal space. So you can move around so that you can better hear the different valves and see if there's anything wrong. And since they close slightly differently, or at different times, then the doctor can get closest to that valve and hear them to see if there's any problems with them. So as the heart pumps, it's pumping out a volume of blood is pumped by each ventricle in 1 minute. And so cardiac output is the heart rate times what's called the stroke volume. And the heart rate is the number of beats per minute, and the stroke volume is the amount of volume of blood that's pumped out by one ventricle with each heartbeat. So the normal cardiac output is somewhere around 5.25 liters per mil. And basically, the cardiac output can be affected by factors leading to regulation of stroke volume and the regulation of the heartbeat. So in here, we can look at stroke volume and figure out stroke volume by looking at the EDV, which is the end diastolic volume, which is the amount of blood right before contraction, right? And the end systolic volume, which is the amount of blood left after a contraction. So the normal stroke volume is about 70 mils per beat because the end diastolic volume is 120 on average minus 50 mils for the end systolic volume. Now there's three main factors that can affect the stroke volume, and they are what are known as preload, contractility, and afterload. So preload is how much can the heart stretch before it contracts? And so basically, so the most important factor here in this preload stretching of the cardiac muscle is the venous return, or the amount of blood that's returned to the heart. And so Frank-Stalling law just is talking about as you increase venous return, you're going to increase this amount of blood that you have before a contraction. Then that's going to increase basically the stroke volume, which then increases cardiac output, right? And so this is what's known as Frank-Stalling law, and it kind of makes sense. Contractility is the contractile strength of each given muscle length. It's independent of muscle strength and this amount of blood before contractions. The increased contractility will lower the amount of blood that's after a contraction. It's caused by basically sympathetic epinephrine release stimulates increased calcium influx, so it leads to more cross-bridging formation. And so you have what's known as positive ionotropic agents that can increase this contractility. And it gives you some examples: thyroxine, glucagon, epinephrine, digitalis, and high extracellular calcium are all these positive agents that can help increase this contractility. It can be decreased by negative ionotropic agents, such as the process of having acidosis due to things like diabetes, and increased extracellular potassium and calcium channel blockers. So basically, it's the idea if you increase contractility, it's contracting more and there's less blood left over. So norepinephrine can actually increase heart contractility via a cyclic AMP second messenger system. So basically what happens here is you can see norepinephrine, which is a hormone, binds the receptor. If you remember, this is second messenger. This goes straight back to our endocrine chapter. So it's going to go over to this adenylate cyclase, and it's going to activate the second messenger. Now, what this guy does is there is a particular what's known as a protein kinase molecule that gets activated. And this is going to basically add a phosphate group to calcium channels that are in the sarcoplasmic reticulum and calcium channels that are in the plasma membrane. Overall, this is going to increase calcium. More calcium binds to troponin, releasing it out of the way so that tropomyosin can bind. More cross-bridging, increase in contraction. So you have higher or increase in contraction, you're going to be able to push out more blood, increasing your stroke volume. And the other way of regulation of stroke volume is afterload, and this is the back pressure exerted by atrial blood. So afterload is pressure that the ventricles must overcome to actually eject blood. So there's this back pressure from atrial blood pushing on the semilunar valves, and it's a major pressure. And the aortic pressure is about 80 milligrams of mercury, and pulmonary trunk pressure is around 10. And as you can see, there's this large pressure for the aortic because it is functioning into the systematic circuit, or systemic circuit. So it is essentially pushing blood to the entire body, where the pulmonary trunk blood pressure is only 10. It's a much smaller system. Now, we also have factors that are involved in determining cardiac output. So cardiac output, again, is your heart rate times stroke volume, or how much blood is being pushed out. And so what helps to determine it is basically exercise. And this is by increasing the sympathetic activity, skeletal muscle activity, and respiratory pumps. And also increases ventricular filling time due to decreased heart rate. If your heart is able to push or contract stronger, it's going to have more time between the beats to fill. That's going to increase venous return. That is going to essentially increase preload, which is basically the amount of blood before you contract, right? And that can come down to help increase stroke volume with blood-borne epinephrine, thyroxine, and excess calcium, which helps to increase the contractility, which decreases the amount of blood left after. And so if you're increasing the amount of blood that you have in your heart before contraction, and you're decreasing the amount of blood left after contraction, then you're getting more blood going out cumulatively. Central nervous system output is in response to exercise. So if you have fight or flight, anxiety, decreased blood pressure, that can either be parasympathetic or sympathetic activities. If you increase sympathetic activities and decrease, then you're going to get increased heart rate. So you have higher stroke volume, higher heart rate. It's going to increase cardiac output. If stroke volume decreases as a result of decreased blood volume or weakening heart, cardiac output can be maintained by increasing heart rate and contractility, right? And so you can have positive chronotropic factors that increase heart rate, or you can have negative chronotropic factors that can basically decrease heart rate. And basically the heart rate can be regulated by autonomic nervous system, chemicals, or other factors. So the sympathetic nervous system, again, can be activated by emotional or physical stresses. For instance, you getting ready for this test. So norepinephrine is released, binds to these beta-adrenergic receptors on the heart, and that's going to cause pacemakers to fire more rapidly, and that's going to increase heart rate. It can also increase contractility. Now, parasympathetic nervous systems oppose this effect. So if you have acetylcholine, this is going to hyperpolarize pacemaker cells by opening calcium or potassium channels, allowing to slow heart rate. This has little to no effect on contractility. So autonomic nervous system regulation of heart rate is there as well. But as you can see, it's not starting or stopping it. It's just regulating if it's faster or slower. And basically, this is just another example and you can see if you can explain to yourself on here the results or how cardiac output can be increased. Other things that can help to regulate heart rate are chemicals like hormones. Epinephrine from the adrenal medulla increases heart rate and contractility. Thyroxine increases heart rate. It also enhances the effects of norepinephrine and epinephrine. Ions, as in intra and extracellular calcium and potassium, are maintained for normal heart function, so any kind of imbalance can change heart rate and it can be dangerous. Other factors that can influence heart rate are age. Obviously, fetuses have the fastest heart rate and it declines with age. Females have a faster heart rate than males. Exercise increases your heart rate. Basically, during exercise, and then trained athletes, if you basically over time you can actually slow your heart rate. Body temperature, heart rate can increase if your body gets warmer. And basically, you can, if you incorporate regular exercise into your diet, you can keep your heart healthy, and you can basically fix age-related changes. And so let's talk about all of these different types of homeostatic imbalances really quick. So arrhythmias are irregular heart rhythms. Fibrillations are rapid, irregular contractions. The ectopic focus is basically if you have a defective SA node, it can lead to ectopic focus, which is abnormal pacemakers that take over pacing. Extrasystole is premature contractions. Now here, if you have your AV node that's defective, it can cause heart block. And heart block is partial block or total block. And this is when you have few impulses reaching the ventricles. Heart murmur is an abnormal heart sound when it hits some kind of obstruction. This is usually indication of a valve issue. Hypocalcemia means a reduction in calcium, and this is going to depress the heart. Hypercalcemia is an increase in calcium. This is going to increase basically heart rate and contractility. Hypercalcemia is an increase in potassium. And so this is going to change or alter electrical activity. And so this can lead to heart block or heart attack, cardiac arrest. Hypercalcemia or hypocalcemia is low potassium levels, and this can lead to feeble heart beat or arrhythmias. Tachycardia is abnormal heart rate, which is greater than 100 beats per minute. If this continues, it can lead to fibrillation. Bradycardia is it's slower, heart rate is slower or less than 60 beats per minute. And so may result in a grossly inadequate blood circulation in non-athletes. But it may be what's desirable if you're an endurance trainer. So if you've worked out and you run really long distances, this is pretty common because your heart is strong enough to get the blood to your body. But if you don't work out and your heart rate is less than this, then that can be a problem. Let me get some of these off of here so I can get congested heart failure. This is a progressive condition. And so this means that the cardiac output is low, so it can't meet the needs of tissue. And so, with that being said, we have finished our lecture on heart. I hope you've enjoyed it.